Thanks, Mark. Really fascinating talks. So I'm just in the middle of my clinics because I got the timing confused between the Eastern States and WA. So good afternoon or evening to people from New Zealand. So thank you for giving me the opportunity to talk. So and present our data for PD-1 expression on circulating tumor cells as a predictor of response to immunotherapy in melanoma. It's a brief outline of my talk today. So I'm sure most of you are well familiar with immune checkpoint inhibitors, but just a brief intro and a couple of slides. Then tissue as a liquid biopsies, and then I'll present most of the data from this small study, and then some future directions. So immune checkpoint inhibitor therapy obviously revolutionized a number of tumor types, and they become standard of care across multiple tumor streams in Australia, using it as frontline therapy now in melanoma, in lung cancer, and neck cancer, bladder cancer, and the indications are growing as we speak. So, so this is the survival data from Checkmate 69 study in melanoma. So you can see the 5-year survival statistics. So about 8-10 years ago, I used to go to my patient, the 12-year survival statistics for somebody with stage 4 melanoma was only 25%. And now we're looking at 5-year survival rates somewhere between 50 to 60% for patients with stage 4 melanoma. So really encouraging. But again, there's still about 40% of patients, which are in this part of the graph, who do not benefit from treatment, and more importantly, my experience side effects from treatment, because these treatments, particularly as monotherapy, they're generally clean treatments, but there are some novel side effects associated with these treatments. But as far as the doublet immune therapy is concerned, there's quite significant toxicity which can lead to patient morbidity. So I think the emphasis, particularly from a clinician perspective, is to try to identify patients who are best suited for treatment with these new novel therapies, and saving toxicity to the patient who are unlikely to benefit from these treatments. Why do we need predictive biomarkers? Obviously, the risk of financial toxicity. Most of these treatments, probably I don't need to tell you how expensive they are. So if a treatment is unlikely to help a patient and more likely to make them sick, so there's financial toxicity associated with the cost of the drug, more importantly, the inconvenience to the patient, and also healthcare cost of managing those immune-related adverse events, particularly if a treatment is not working, why harm a particular patient. But I think that the practice of biomarker is to try to treat the right patient with the right drug at the right time. So in terms, there's a number of biomarkers that are being evaluated. There are a lot of papers being published, but I think in terms of routine clinical practice, the one that we use mainly in lung cancer is the PD-1 expression. And there's some conflicting data in melanoma, and in this PD-1 data coming from GI cancers and bladder cancer as well. But I think the vast majority of data support that if you've got a high PD-1 expression, you're more likely to have a higher response rate, in contrast to if you've got a low or no PD-1 expression, where your response rates are likely to be somewhere between 15 to 20%, versus about 50% in patients with high PD-1 expression. Now, using just PD-1 expression is just a small aspect of this heavy traffic that you can see in the tumor microenvironment. So clearly, PD-1 expression in itself alone cannot be an accurate reflection of what is happening in the tumor microenvironment. As our understanding of the tumor biology and the tumor microenvironment improves, so hopefully with time we'd have a better understanding, and maybe I think in contrast to targeted therapy, where, for example, in melanoma, we got a BRAF mutation, which is the driver mutation, and we measure that the patient got a BRAF mutation, and then those who have the mutation get the drug, and those who do not have the mutation, so binary biomarker seems less likely will have a sort of a binary biomarker predictive of response to immune therapy, purely because of the complexity of the tumor microenvironment. So standard biopsy is obviously difficult, so we not uncommonly struggle only to get a diagnostic biopsy, particularly in the context of lung cancer or pancreatic cancer, for example. And it's very inconvenient to the patient. Sometimes we need to have 2 or 3 goes to try to get a diagnostic sample. And then to make decision on that, particularly, for example, if you see somebody with lung cancer who's had surgery, early stage disease, and they relapse 4 or 5 years later, so clearly their tumor has evolved So making a decision on that initial sample from 3-4 years ago might not be relevant at that stage, and tumor evolves with time. That's where the liquid biopsy particularly helps, because you can get a pre-treatment sample and you can do it longitudinally to try to assess your response and also identify markers of resistance. And you can use it in different settings, as some of the data was discussed earlier today by Leslie, for example, to try to track your tumor response kinetics with drop-in CTDNA levels and then correlate it with the imaging. And some of this might precede the response that we detect on imaging, and we might be able to appreciate it earlier. And same in surveillance as well for early stage condition like stage 3 melanoma, where you might be able to detect relapse a few weeks to a few months earlier than what you would expect when in the context of standard imaging. And then Regent County University Melanoma Research Group lab led by Professor Alan Gray and Professor Mel Zimmern, so who's retired now, is looking at various aspects of blood-based biomarkers. So this in the background, so this study is looking at, trying to look at the predictive significance of pre-treatment PD-1 expression of circulating tumor cells in advanced melanoma patients, because the problem with the tissue biopsy is that you might not be able to go back to this diagram. So one needle biopsy might not be an accurate reflection of what is happening in the tumor microenvironment. So if you sample this part, it might be PD-1 negative, whereas the truth might be that the vast majority of the tumor might be PD-1 positive, or the other way around. This is probably one of the reasons that we see responses in PD-1 negative patients as well. So we thought that maybe if there's any level of PD-1 expression in the tumor microenvironment, or if you were to look at PD-1 expression of circulating tumor cells, which is more of a broader reflection of what's happening in the body in a cancer patient, we might be able to see if it correlates better compared to standard PD-1 expression. Then also looking at the predictive significance of post-treatment changes in CTDNA levels, which Leslie already presented, but also in the CTC levels as well. In this study, which was initially funded by MSD kindly, and then some research grant from Cancer Council WA, NHMRC, as well as RAIN Foundation and Spinnaker Health Foundation in WA. So we recruited 58 patients with advanced melanoma treated with pembrolizumab in the first line or in the second line setting. Out of those 58 patients, so they were from three tertiary care hospitals in WA, and their samples were taken at baseline and then somewhere between 8 to 12 weeks after starting treatment, depending upon where the sample could be collected and where when the scans were done. So 18 of them were excluded from the study because of, some turned out to have more in the adjuvant treatment or pseudo-adjuvant treatment. 3 did not pass quality control. So eventually we had 40 patients. 70% of them were males primarily, so they were advanced stage melanoma patients, and then 63% of them were in the first line setting, and again, sort of almost 2/3 of those patients were wild type, really a reflection of that, the fact that in Australia we couldn't use first line immunotherapy up until very recently. BRAF mutant patients were treated with targeted therapy. Only in the context of trial we were able to access immunotherapy for these patients. So patients were dichotomized into those with at least one positive PD-1 positive CTC versus PD-1 negative CTC, and ROC curves were used to discriminate responders versus non-responders, and Fisher's test was used to assess the association between CTC, PD-1 positivity, and response to treatment. And then we did Cox regression analysis as well. Probably skip that. So out of 40 patients, so we found circulating tumor cells in 25 patients, and there's a multi-parametric flow cytometry, and there's some data presented by published by Ellen previously, which is looking at various markers and the heterogeneity of circulating tumor cells. But in our cohort, mainly it was ABCB5 and rank tumor-initiating markers which were present. So we found 25 patients with circulating tumor cells. And then when you look at the PD-1 expression on those circulating tumor cells, these red bars, so you dichotomize them into responders and non-responders. So the responder cohort was more enriched for patients with CTC, detectable CTCs, which were enriched with PD-1 positive circulating tumor cells. So the main slide of this study, so this is the progression-free survival and overall survival Kaplan-Meier curve. So the median progression-free survival was about somewhere between 5.5 months. So those who are CTCs, PD-L1 negative, versus somewhere in excess, somewhere between 25 to 30 median progression-free survival, which hasn't been reached, but it's somewhere between 25 to 30 months. If you look at the 12-month progression-free survival percentage, 22% versus 81%. So really intriguing data and interesting data that needs to be reciprocated in or verified in the context of a larger trial, which is sort of more standardized in terms of response assessment as well, and in a bigger sample size. In overall survival, so there was a difference, there was a trend, but it was not statistically significant. Looking at the tumor response kinetics, so the green bars are in responders and the red bar lines are in the non-responders. So responders had either a low sort of CTC PD-L1 count to start with, and then there was a decreasing trend at follow-up in the responders. Whereas in non-responders, the CTC PD-L1 expression as well as the total number of CTC either remained static or increased. It's sort of similar to what we saw in Leslie's data for CTDNA analysis as well. So when you look at the total number of CTCs between responders and non-responders, there was no statistically significant difference. But when we looked at the number of CTCs with positive PD-L1 expression responders at a higher count, but again, we might mindful of the fact of the smaller sample size. In terms of ROC curve, to try to discriminate between responders and non-responders. So if you got one positive PD-L1 positive CTC, so the sensitivity and specificity was 62% and 78%. In terms of Cox regression analysis for univariate and multivariate analysis and balancing for important confounding factors like age, equal performance status, BRAF, and then liver metastasis and neutrophil lymphocyte ratio and PD-L1 expression. So PD-L1 expression on CTCs was statistically significant on univariate as well as multivariate analysis. And we also looked at in a limited number of patients, how does this correlate with tumor PD-L1 expression versus circulating tumor cell PD-L1 expression. So we had 40 patients in total. Out of the 40, we had PD-L1 samples available for tumor on tumor tissue for 25 patients, and then we had data for only 14 patients were available who had both CTC PD-L1 expression data and tumor PD-L1 expression data. And out of those 14 patients, there were 6 patients who had double positive, meaning they were CTC as well as tumor PD-L1 positive. All 6 of those patients responded, meaning they were double positive. And there were 3 patients who were double negative, meaning negative in CTCs as well as on tumor PD-L1 analysis. And all 3 of them were non-responders. And then there were about 5 patients who were either CTC positive or tumor PD-L1 positive, and the responses were a bit not well defined in those patients. But you can see in these bars, the higher the PD-L1 expression, so in responder, whether it's CTC PD-L1 expression or tumor PD-L1 expression, you're more likely to have an enriched cohort for responders. Again, you can't use that as a binary sort of cutoff definer between whether you're going to treat that patient with treatment or not, unlike BRAF mutation that we see. So moving forward, I think one of the interesting aspects led by Ellen is that circulating tumor cells can serve as a surrogate marker to study tumor copy number alteration. So looking at some data from Jennifer Vargo's group, so if you got a copy number loss, particularly in chromosome 6 and 10 and 11, so you're likely to have a more resistant, immunotherapy resistant tumor state, and these are non-responders, and that's what we saw in this one patient who had a tumor analyzed and they were chromosome 10 deletion, and then also in the circulating tumor cells. So you can see that in the tumor as well as in the circulating tumor cell on single cell analysis, quite an interesting field moving forward. And I hope that we'll have much more data coming through in the next few years looking at single cell analysis. In terms of limitation of the study, as I discussed, small sample size, and circulating tumor cells are not detectable in about 1/3 of the patient, but that's reflected to disease biology. I think there were some questions sent around that patients with brain metastasis, you might not isolate sort of liquid biopsy markers, and then they could be related to technical limitation. We clearly need to work on that. And then tumor response assessment as well. Obviously, we're trying to correlate response assessment with progression-free survival, and because if it is not in the context of a randomized or a controlled study, so the scans were done at different times, so obviously that impact on your progression-free survival. So if you do the scan at 8 weeks or 12 weeks, your progression-free survival might be artificially prolonged if you're doing the scan later, because you're finding out about disease progression later. So in conclusion, so our results reveal that there's a potential of circulating tumor cell as a non-invasive real-time biopsy to evaluate PD-1 expression in patients with melanoma. And PD-1 expression of circulating tumor cell may be predictive response to immunotherapy. And moving forward, we need to improve our understanding of the tumor microenvironment and disease biology, and use potentially circulating tumor cells for single-cell analysis and correlated with treatment resistance and response. I'd like to thank the participants of this research, and particularly our research group led by Alan and Mel, and all the other collaborators. So I'd like to thank them all and the funders of this research as well. Thank you.